We just never give up. Well, we're live. Hello, America. Happy Friday.
Wow. Yikes. Didn't realize we
Happy
were live,
Friday.
but here we are.
We're live.
Here we are.
We have CMSRFI commenter number 258. As Michael noted, there are several hundred comments already in on the RFI, according to the internet. If you want to be like me and wait until the deadline, which I feel like is what everybody
The
does,
16th, yes. Put it in the 16th. June 16th is your deadline.
maybe we can be like number thousand somethings together. I'm very excited about it. Lisa, have you already sent in your comment letter?
No. But what we have noted is that there's someone doing a stock like pump and dump scheme with Clover Health. Brendan, our friend Brendan Keeler wrote about it on LinkedIn just now about how someone is like posting like hundreds of comments for Clover Health and being like, Clover Health already does this like a
Oh my God.
billion times.
Well, you know what? I feel like that's just part of the move. Well, we have Megan here.
Guerrilla marketing.
Megan,
Guerrilla
we're already
marketing.
live. Dr. Megan Ranney is here. She's our special guest. We have this guy's actually Michael Marchant. So loyal fans, we have a different format today. We're going to do about 15 minutes of our news show. We're going to have Megan on until about 5:15, and allegedly the commander, Commander Michael Banyas, is coming on right at 5:15 to take over for Megan, so she can go. I don't know, do her public service. We don't know what she's going to do. And he's going to tell us about the SBIR grant period that's open, I think, until June something or other. So very exciting. We were supposed to have a whole show with the commander, but as you all may remember, Newark stopped our plans there. So Megan,
That's right.
we're gonna send you behind the scenes so that you don't, get fired or anyone thinks that you're associated with all the bullshit we're about to say, and we'll bring you back on in about 15 minutes. Michael, you can come on and on whatever you want. You know what to do. Okay, Lisa.
Amazing.
We should tell our loyal fans too. So, dear America, we also had a special, like our first ever recorded show this morning.
Not live,
It was so weird.
unfortunately.
Yeah,
Yeah.
we had like actually like it's not our normal show format, but we did an hour long bullshitting conversation with Joe Grogan. Some of you remember we were on his show, DC EKG, in the fall. It was really fun.
Yeah, he is hilarious. Whether you agree with him or not, he is very funny, and he thinks we are very funny, which obviously is great because we
We love
appreciate
that.
that. Yeah.
Yeah, we're into it. But yeah, I think we're probably going to release that show recording. It was weird timing for everybody. He is based in London, so we're probably going to release that next week. We did talk about the RFI. We talked about health tech in general, health data, all those things. He had a lot of feelings about meaningful use, the original sin, as he kept saying. So
That's right.
it was really fun. So we'll put that on the internet at some point next week. So Lisa, what else happened other than the news?
Oh man, there's so much other news. I don't know. I'm just busily preparing for a big trip to our nation's capital, which is, I think, having like a major flooding event right now. As per usual, the weather is
Are you
terrible.
talking about Mar-a-Lago?
No, 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 the northern one. Or no one's ever called DC Northern except for just now,
The
but
other
you know,
the other capital of America?
the other
Got it.
capital of America.
Got it.
The
Got
swampy, the original swampy one. Wait, no, that doesn't make sense. They're both swampy. I don't
it.
know.
Yeah. Awesome. Well, another breaking news, we just got a breaking Politico Pro alert that says Trump agencies tell Congress what to chop and 22% budget slashing. We'll read that later.
Nice.
That's exciting. So that's continuing to happen. I guess any of us that thought that we would have um, we'd have less cuts coming up here in the summer. I don't know. We'll see what happens. But all right, let's go to the news show. So Lisa, this is something you sent about, like just this random dude who seems legit, talking about should AI replace therapists. I feel like the answer there is no, and he agrees. But like, why is this exciting?
It's not like exciting. It's just like this is more evidence of the danger here. If you look at the bigger, like not health tech picture right now around AI, there are all these, people saying like, "Oh, what are people using AI for?" And it turns out it's like mostly chatting. Like humans are not very smart. Just just to be fair. And like all we want to do is like chat with the chat bots. And people are using them as like de facto therapists, or let's call them spicy therapists. And that's like what people want with technology is generally in the porn side of the universe here. Like that's what people are using it for the most part. And it's
Romantic companions.
upsetting, but not like surprising to me because like we don't really have that many needs. Like that's kind of what it is. And of course, it's very concerning. Like, you should not use a chatbot as your therapist. And here's more evidence as to why not. Like, it's not safe. I mean, it's fine if you want to like chat with the AI bot, but like, that's not a human being. It's not a therapist. It's not trained. It's not a licensed clinician. And it could actually cause harm. And so there's just more evidence in that direction. So,
Yeah, yeah.
yeah.
We did talk a lot with Joe Rogan about AI and if or if not, it's going to save America. He's bullish, and he says that he has come around to it, maybe not saving America, but being great. A cool avatar. I would still say no.
I mean, I didn't get from Joe, we shouldn't talk too much about it when I give away the amazing conversation we had. I didn't feel like it was like there's a reason. It's more like we need something. Yeah, it's not Joe Rogan, everyone. Joe Grogan.
Rogan,
Grogan. If you
former,
are if you, yeah,
he's a
not
fellow at USC now.
yep,
I can't remember, but yeah, he was domestic policy counsel and Trump won. So he's
that's right.
definitely, like, if anyone here thinks that I'm right of center on free market dynamics, you have something else coming to you. Because I was like, oh wow, like he's a
That
all
guy's
right.
for real.
I'm over there with Lisa on that side. It was pretty awesome. Okay, this was just a funny thing you sent. So today, I believe today is Elon Musk's last day as a special government employee, and not head of Doge, whatever he was. But this is a funny little story about a Doge staffer who. This was like hilarious to me because it was interesting, but then the funniest part is he was shocked that he was fired after
He
telling
was
fast.
doged. He got doged. Yeah, like what's the point here? I think there are some people, like, bless their hearts, who were like, I'm gonna go make government better. And like the funny part about this article is he was like, yeah, like it wasn't actually very inefficient. Like, and we had some good ideas, but like we couldn't implement them. I'm like, yeah, sounds about right. Sounds about
Yeah,
right.
sounds
That's how it
reasonable.
goes.
Yep,
Yeah.
yep. Anyway, yeah, and he also says like, oh, it's government actually works, just like a little slower. I'm paraphrasing, but he was like, I thought it was going to be shittier.
Exactly. Like
Um,
it's just
we got- we got-
like it's just the endless like we've heard
Scott.
this a million times. We heard this
Yeah,
all the time. All
yeah.
right, cool. Great.
Anyway, we'll send Scott back. Yeah. All right. So this was a story from this morning. This is more discussion about the CMS ASTP RFI. And as many of us, I believe, know, Amy Gleason, Artakara, and some other people, they weren't mentioned in this article, so I don't know if we're supposed to say their names, but all involved in pushing out this RFI from CMS and doing a lot of thinking on this. I thought this was a good piece. I thought Amy did a great job. Arta did too, talking about what they're kind of thinking and where they want to get input, but then acknowledging like this is not going to happen overnight. So that was
Yeah.
good stuff.
Yeah. Yeah.
Yeah.
That was a good article.
Any other stuff that we are thinking about the RFI, Lisa, while we're on the topic?
I mean, apart from like the like pump and dump scam that whoever is like got a position in Clover Health is putting, like it is worthwhile to like provide your perspective here. Like I think anybody listening can provide a perspective back to CMS on this. Again, as I will always say, you do not have to answer the whole thing. It is very long. Answer the part you want to answer. Answer generally. You could just write a response back. Like, but you can give them sort of your view. Like the vibe is this is about the health technology ecosystem. So they're saying we want to allow and let a thriving private sector health technology ecosystem thrive in whatever we're trying to do here. So, what are your thoughts about that? Everybody listening probably has a thought about that. And I do think it's honestly valuable just to like give your thoughts back to them. They're asking for comment. Provide your comment back. Take it
Do that.
seriously. Yeah,
Yeah. Into
easy.
it. Yeah, love it. So everybody do it. And you can respond as just a regular human.
Yeah,
Just like
you
all
can
the
just be like,
people
it's me.
everybody for Clover Health out there. There, you can do whatever you want to do. Go do the thing.
Cool.
United Healthcare continues to get its ass kicked. This was a little expose in the Guardian. Yeah, apparently they're,
Would not want to be working in corporate comms for United Health Group. That's what I can say.
I'm not sure I want to be working with them in general right now, especially if I was largely compensated in stock.
Not good. Yeah. Yeah.
Yeah. I mean, the other thing is though, it might be a good time to buy United Health stock because, I don't think it's going to go away. So, it's probably.
Go for it. You're not ever planning on working in the government. You can do it.
Yeah, just do the thing. So we saw Hinge Health. Actually, I haven't seen, how is their stock doing now? How's Hinge Health doing now?
I think the first day was positive. That's the last thing I read about it, is it was like they did okay on the first day.
Yeah, I think there's usually lots of ups and downs and all that stuff. So,
yeah.
But it was considered a successful IPO. And so people are bullish on Omada going public, which is exciting. 1.1 billion, it's like more money than I have.
They opened at the previous close. Yeah, they're in the range. They haven't had like a dramatic like crash or whatever. It's fine.
No dramatic crash. So that's positive. A+.
They haven't had a dramatic crash. Like, it's been okay for what.
Yeah, but it sounds like Omada is going to do the thing. That's exciting. They've been not public forever. People have been saying Omada is going to go public for like 100 years, as far as I know. Excited for them. Everybody needs a good exit now and then. So looking forward to seeing what goes on there. I'm also looking forward to see if Matthew Holt writes like an exceptionally long Health Tech Nerds Slack post about Omada that I will not read, but you will tell me about. So
That's right.
Yeah. Okay, what else we got here? This might be our last piece before we shoot over to Megan. So it looks like a lot of plans, not just the Blues, are pulling back on their GLP-1 coverage already. And there was lots of commentary on Health Tech Nerds about this. Some people are saying this is just, it's hard for them to achieve an ROI before they pass it on to another health plan, or them being a patient going to another plan, and then it just being very expensive. So I don't know, or this could just be like the Maha movement, people just wanting to align with the current administration. I don't know.
Like the AF-CAT, like easily 59% of the population are currently taking GLP-1s. Even people who are in the Maha movement or whatever. Come on. Everybody's taking it.
I don't know. I will say this.
Then they are just BSing. There are not enough people. There are a lot, like a absolutely non-trivial portion of the US population is currently taking GLP-1s. Like a huge amount of people. No way. The 5 people in Maha are not like, it's not this. Even them, they're also taking it.
I don't know. Maybe. Who knows? But
I think it's the cost. I think it's exactly what you just said, right? Like this is really just a consequence of, our health system with so many people with employer sponsored coverage. Like, yeah, Scott, 59%. That's what I said. I'm sticking to it. Scott doesn't believe me. Scott is questioning my 59%. I'm like, yes, 59%. That's a real number that I just made up.
Listen, Scott, we're about to talk to like a real actual public health expert about numbers and stats and spreading misinformation. And I feel like Lisa and I know how to do all of those things. So, your math is, I'm here for it.
We have real numbers.
Yeah. This is just about a lot of the stuff with the ACA in the big, beautiful bill. It looks like people this big, beautiful bill is like really freaking big. Like there's a lot of shit in there that people aren't paying attention to. Like Lisa, we talked this morning about HSAs. There's some interesting stuff in that might go through about increase in HSA amounts. Again, there's some issues here with ACA subsidies for even the exchanges. So you're hearing about Medicaid expansion, right? Obviously, like that's a huge issue. And there are subsidies to the states for that, but there are also just subsidies for people going on the exchanges so they can afford healthcare coverage if they don't qualify for Medicaid. So a lot of this stuff is like, really on the table and like will impact a lot of people.
Yeah.
I don't know, I don't remember too much, pre-ACA insurance costs if you were on the market yourself, if you weren't going through an employer, like if you're a regular human getting commercial insurance, it was like grossly expensive. If anyone remembers, it was more than your rent. It was more than your mortgage to be
And they
insured.
could kick you off with no problem and just not cover anything that was a pre-existing condition, which was an extremely generic like thing. As somebody who has a very like often sickly, injury-prone dog, pet insurance is also excludes pre-existing conditions, and so that's why I have kept her now very expensive pet insurance for like a decade because literally if you move insurance coverage, it just doesn't have the same rules, rightfully. It's not regulated in the same way. As a human, yeah, I mean, I wouldn't be able to have insurance if we didn't have these coverage provisions. Absolutely not.
No, I mean, now we all complain, like if you switch jobs and you have to
I'm
get COBRA.
old. I have
Like,
like a bum hip and like all kinds of other problems.
yeah,
Like I
Lisa,
wouldn't work.
Lisa, you got to watch out. Is all I got to say about
That's right.
that.
That's right.
But I'll take care of you. Don't worry. But
Thank you.
no,
Thank you.
like do you remember, like you used Cobra. Remember now everybody's like Cobra's so
I
expensive.
remember.
But
Why
yeah,
would someone pay so much for Cobra? I'm like, Cobra exists because it was literally a problem when you lost your job or you changed jobs. Like you needed to continue that insurance. There was a
Cobra
reason.
was so much cheaper
Yeah.
than getting
Yeah.
your own private insurance. And now
Totally.
because like I mean it actually really like
Yep.
the ACA and the exchanges like really actually have changed the landscape. And I think it's hard for people to remember the old timey days, but you know, 'cause
Mhm.
we're old, Lisa, we're like in our 40s, so holy shit, like we
Yeah.
remember a lot. But you know, there's people that
Don't trust that there's a lot of Botox in here, different places.
that's what I'm talking about. See, I was just saying that to someone like
Not
this is
covered by
not
insurance,
natural.
obviously.
Yeah, yeah. That's great. Not covered
That's
by
right.
insurance.
That's right.
Anyway, we're gonna move on to talk to our real guest. So
That's
let's bring
right.
her up here. All right,
Real
Megan, we didn't do
guest.
that on this show. Like, I don't think we didn't curse that much or anything, but
Hi, it's lovely to be brought in. I just totally enjoyed that banter and now have a couple new articles to add to my reading list. So thank you both.
Great.
fantastic. Well, Megan, I feel like everybody thinks you're a hero, but like we might have like 4 fans watching who don't know who you are. So please introduce yourself.
Thank you. So my name's Megan Ranney. I am an emergency physician and injury prevention researcher by training. Have done a lot of work over the past decade or so to try to develop innovative approaches to public health here in the US and a bit globally. And I'm now the Dean of the Yale School of Public Health. I've been in this role for 2 years, have ushered our school into independence, done a spinoff of sorts, and continue to do a lot of work on the national stage as well.
Very cool. Yeah, I mean, you are, we see you a lot. And I know a lot of people depended on your voice during the pandemic to get through, you know, and cut through the clutter. And
Right.
you're a trusted person in what we'll call public health, I think. And so I think Lisa and I mean, we always notice you because you're all over the place. But one of the things that I picked up recently that I really loved was that you did, I thought, a really nice come to the table conversation. I think it was on the Why Should I Trust You podcast or a YouTube show. And I will say those were long, so I did not watch the entirety of them, but I did listen to, I think, just 2 episodes. I didn't get to the end of both, but I really liked your approach to those things. And I think we want to we just want to talk to you about like what you're thinking in terms of like bridging the gap. Cause I know I'm rambling here, but
In these troubling times, Megan.
yeah, I think, you know, I'm of the opinion, just to put it out there in case no one's noticed, I think more conversation is better. And I know like the very extreme comments that come to people like me, and I saw there were some in the comments of the post was, you know, you're just validating this awful approach. Or I get some people say, well, would you negotiate with Hitler? And I'm like, Jesus Christ, like you're using the exact awful communications tactics that you see on the other side. So I certainly appreciated that you did that, but I'd love to just hear, you know, your opinions on why you thought that was important and what you thought came out of it.
Yeah, thank you. I mean, I'll be honest, it was an honor. It was a little bit nerve-wracking, but it was certainly an honor to get to do that. I have spent my whole career, thank you, Emma, for the kind comment. I've spent my whole career trying to bridge perceived divides. I deeply believe that most people, not just in the US, but across the globe, care about their own health, that of their family, their kids, their parents, maybe even their community. And that where we fall apart is when we devolve into political partisanship and mudslinging instead of actually talking about underlying health problems. And when I have listened to the MAHA movement, not necessarily to the people at the very tippy top, but to the folks who are kind of the steps below, that is their motivator, right? And so to get to be in a conversation and to understand, why did they join MAHA? What is it that they are hoping to get out of it? What are their perceptions about the work that I and my colleagues do in public health and healthcare? And where is there a disconnect? Was an incredible opportunity. I wasn't sure going into the conversation what I would hear or learn. But I will say, Kat, it absolutely reinforced to me exactly what you just said, which is you need to start with conversation. Both of those podcasts resulted in finding a lot of areas of really deep agreement. There are certainly still some areas where we're not fully aligned. But whether it was around stuff like exposure to chemicals in the environment, around the opioid kind of epidemic and the rise in overdoses, the need for improved nutrition and obesity prevention, like those are all basic public health concepts. And the things that I'm doing haven't been making my way to them, and then vice versa. So I think it's leading to some opportunities for collaboration for the sake of the health of Americans, which is like why I'm in work. So.
Yeah. And Lisa, I don't know if you had a chance to watch all those. This might be the only thing that I've watched that you haven't. I don't know.
I did not. I didn't get through all of them. Same thing as you. But I also just think I agree, and it's being able to understand how to react or not react when something gets to a place that feels really like sensitive for us, right? I have a lot of feelings about the space. I really do. I also have learned over the past, decade, being in and around DC and policy work, just like how dangerous and difficult it is to be an extremist, right? In any direction, because certainly things are complicated, right? I knew coming out of my my policy degree that there were obviously lots of opportunities for unintended consequences of policies. But then you really see it, right? And you see how it is a bit humbling because there are so many things that can happen when we pursue or pass certain laws or pursue certain policies. It's not that straightforward. And then I think generally as you get older, you just start to be like, yeah, it's not so simple, is it? Right. So I think it's good to remember that, but it's also hard to not be really to be reactive when you talk about things like health and safety and people's futures and stuff like that. So
especially at this moment where it feels like so much of the infrastructure that supports health in America, which, let's be honest, like the systems are broken. And all three of us would agree that the systems are broken now, have been broken for a while, and got much worse over the past 5 years, right? And those broken systems are being destroyed even more. And so it does become especially difficult to listen in those moments. But it also becomes more important. And Lisa, your comment about how being an extremist is dangerous, I'll say kind of before the COVID work, most of my own research, I worked in, around kind of health tech, but then also around injury prevention and particularly around gun violence.
right.
And one of the things that I have spent the last 15 years doing is creating alliances between unlikely bedfellows to try to move firearm injury prevention forwards. And we often talk about those unintended consequences of some policies and how policy passage alone is not sufficient and sometimes not even necessary in order to move us forward in terms of preventing firearm injury. And so in some ways, this conversation with MAHA felt similar, where it's like there's this group of folks who feel like they've been forgotten or ignored, aren't being listened to as part of the solution. And I may not agree with them about all of the details of the diagnosis and what the solution should be, but like, we're not going to make any progress towards fixing that broken system if we can't at least start with having a conversation, while also acknowledging my experience, which is like active defunding of research and firing of, public health officials who I think do really good work. So But then on the other hand, they've lost family members to opioid overdoses after being told that oxycodone was safe and to just
Right.
trust Purdue. So I get their distrust.
Yeah, and I think there's a lot of like I totally get it too, and I think that to be fair, like yeah, you look at the opioid epidemic, you look at pharma, you look at a lot of bad things happened, and the great federal government, right, did not step in when it needed to, right? There and in some cases helped it get along, so that's not great. And then looking at COVID, there of course were some really bad communications flubs. By CDC. And I think it's worth just saying like that was awful and did create a lot of mistrust. But a thing that I loved about the conversations that I did see is there was an individual who was talking about the line by line, right? Like getting in there and really digging it all through. And then you were like, whoa, it's like a lot. And what I was thinking throughout that conversation is, yeah, who does that aggregation and how that person has to have the trust of the person that's taking the information, right? Which is tricky. But there's even some distrust with like the source research, people don't trust it, right? And so it's like when I was listening to this conversation, which I thought you did a great job on, I thought, like you said, people kind of all were agreeing. There certainly were some parts that stood out, but I think that's the point of all getting together and having more conversation. But how do you solve the big mistrust or distrust problem when it goes all the way down to, can we even trust the people doing the research? Can we even trust the studies?
Yeah. I mean, Kat, if I had the answer to that, like, yeah, exactly. I wish. I mean, I think, so I think a couple of things. I think one is that it starts with relationships. People used to feel like they had a relationship for whatever reason with their doctor, maybe with the Surgeon General, with Walter Cronkite or Tom Brokaw, right? That there were these people who they felt that they trusted and had a longstanding relationship with, and that has been lost. And so we need to recreate it. I think that we in academics and in public health need to think about how our work is translated into and used by communities in ways that like has not traditionally been the emphasis of academia, right? Like you don't get rewarded in academics for doing public communication. You get rewarded for getting grants and writing papers, maybe for having policy influence. But we need to shift that and teach people who are scientists and public health specialists and physicians how to communicate. And then I think we need to create partnerships between, I don't know, novel communicators. My kids, I have a 13-year-old and a 16-year-old. They don't read the newspaper. They don't watch TV news, right? They don't really honestly even listen to podcasts unless it's something on YouTube. How do you create those partnerships to help start recreating trust and making sure that those messengers are actually using data that's trustworthy? I think it's a multi-step process, and it's going to be done by a lot of us. Like when I look at the people that were in that podcast with me, Caitlin Jadalina, who's runs the Your Local Epidemiologist Substack. We had Reed Tuxon, who runs Trust for America's Health. Like it was a group of folks who have different kind of circles. And then the people on the MAHA side had different circles. And so to me, the step towards recreating trust is starting to recreate those relationships and then doing bidirectional sharing. So I'll give you one example. Based off of that call, Caitlin and I, or our School of Public Health and Caitlin and Your Local Epidemiologist had previously worked on a vaccine kind of info sheet. We listened to the questions that both of us were getting from social media and had put together a series of kind of Q&As. And after that first podcast, we've since shared it with some of the people that were on the podcast with us from the grassroots MAHA movement in Ohio and are revising it accordingly. We now have their trust and vice versa, and they're going to share it back out with their community. Is that solo sufficient? Absolutely not. But I think it's at least a step in the right direction.
Yeah, I agree. And I think one of the comments I made on your post where I was just like mad that some guy was saying the Hitler thing was like, so like, I know like you guys do real science. At least when I do like,
I try,
behavioral science, right? Like, But they're actually like, this is actual science, like how you can get people to collaborate and how you can change people's minds. Like there are like studies about this, and what you're doing is exactly what is proven to work most often. The other thing like that you just mentioned is like kind of the next step. And this is what we try to do when Lisa and we were out there like persuading the market to do cool stuff that we think is a good idea, which, depends on the day, is getting the other party to collaborate with you. And in a great, like big world example, this is
Right.
Speaker Mike Johnson all of a sudden having to like be the guy who gets people to negotiate and collaborate. Guess what? He's no longer super duper far right of center. He's pretty close to the center because that's how you have to get things done. And so I do think getting people together so they have to achieve a common goal is like the number one way to do stuff. So I applaud you for doing that work that I'm sure no one is actually
you two can be part of it. I mean, I'll actually say it's part of our strategic plan for the Yale School of Public Health. It is one of our strategic priorities is nurturing trust, the public's trust in health science. But it is not a Yale School of Public Health alone venture, right? It's an all of society thing. So the three of us can keep having conversations, and all the people watching your podcast too. I do think it's
the millions of fans.
The millions.
Millions.
Well, so I want to pick up on something, that you obviously wrote a lot about, Kat, and apparently are now booking keynote talks about.
People are having me come speak about kernels of wheat and bagels.
Yeah. But she's talking about, we jokingly called it her Redneck Public Health series, where she's talking about making these things very, very real to people who may not see themselves in normal sort of policy debates about public health, and how public health obviously, reaches so many parts of our lives. And that kind of got into, there was some back and forth, comments here, comments there. And really, it's clear to me, it's clear to us, I think, that a lot of people who are scientists doing really important work, or public health policy leaders even, might not understand the importance of having those connections and talking and honestly, like, ugly word, but selling their work. Ugly word to some people, not to me, not to us, but
Not
like
me.
the positioning, the communication, the persuasion with trust building is a really, really important aspect of this, and people don't seem to universally think it's a very important aspect of this, and we would heartily disagree.
I am totally with you, Lisa, and I have to say, Kat's posts around kind of deer and not kind of getting diseases from deer hunting thanks to public health.
Right.
Like this, it truly was brilliant and outstanding. And coming from a family where, grew up in Buffalo, have family in Western Pennsylvania, right, in Ohio, like this is real. Like people don't, when I say I do public health, people have no idea what I do. When I say I'm doing emergency medicine, everyone's been to an ER. Nobody understands how the public health side of stuff touches them. But literally the public health side touches people every single day in thousands of ways that they just don't that is not tangible.
That's right.
Yeah.
And we've talked to a bunch of other public health people who, they're like, well, we were taught that we shouldn't talk about it, right? Like we did a good job when nothing happened. And so like they do recoil a little bit when I'm like, get out there. So it's tricky stuff. And the other thing Lisa and I talked about, and we had the bagel thing, is there was a funny post we did earlier this week. And I was talking about like, how you sell and package, right? And you have to speak in the way that your community wants to hear and where they go to listen. And I made some little joke about like, you can't give someone a kernel of wheat and tell them to make a bagel. You have to give them the bagel. And Lisa's pro comment was, I am the bagel, which,
the bagel.
But yeah, I think that I do think that it is, especially for like real serious scientists and academics, right? Like for them to go make a TikTok about their work seems like a stretch too far or very uncomfortable. But I think that like you said in this YouTube with the Maha Ohio people, before there used to just be a few news outlets, right? Which is a different world and had its pros and cons. And now there's lots of different avenues to get communication that are very individual. And if you put your message out there, and before, you'd get like ABC News and some legit reporter to read through your stuff and they do the processing for you. Now, if you don't do that processing, who the hell knows where it's going to go and why and how it's going to be taken out of context in a million different ways. So you have to do the work for your audience more than I think people are used to.
I think that's true. I also think, it's funny. I was actually meeting with one of my faculty on Wednesday around a project that we're working on. And there were a few of us in the room, and we were talking about the communication side of things. And this faculty member was like, yeah, I have zero interest in being any sort of public face. You guys get this. And I was like, that's totally cool. Like, that person is leaning into their strengths on the project, and others of us can lean into our strengths. And this is where I also think that these collaborations matter a lot.
Right.
Thinking about, Kat and Lisa, you guys are awesome. You just, in the first 15 minutes of this show, highlighted some of that was science and some of it was reporting. But I think
some of it was pure opinion and attitude.
Well, that too.
Also true.
Yeah.
Oh, sorry.
Go ahead. No, go ahead.
Yeah. No, anyway, I think that, I think that people need to take a couple steps forward and do the cool stuff and get themselves out there and know it's their job now too. I mean, like one of the things we highlighted on a previous show, it was I always say NIOSH, but I think people say NIOSH. I don't know. Anyway,
potato.
Who knows? They're in West Virginia. They were largely cut. They were like the whole thing was abolished during one of the, I think, the April 1st RIF, and 400 of them were brought back. I said it was because of my farmer's lung post, but it was really because of Senator Capito in West Virginia and some others there. But one of the comments that we highlighted that I was so mad about is that one of the, I actually don't know what his title was. Some leader within that group was saying, oh, wow, they only brought back the parts of the agency that were featured in the press and had the good feels. And I was like, no shit. And that is your job. Go. Now you know the answer. Go do more of that, right? Go tell the stories and tell people what's going on. So yeah. I don't know.
We have to reward it. We have to teach people how to do it. And we have to partner folks, again, with people who are good at it. Because just like not everybody's good at data science, right? Like not everyone is strong quantitatively. I'm not saying you can't,
everybody know what the reality is here.
But we all have different strengths. So I'm not going to, someone who is like my most brilliant epidemiologist, but really doesn't want to get in front of a camera, I'm not going to make them go in front of a camera, but I am going to match them with someone who's comfortable with that part of things. And I'm at least going to give them the basic skill set in the same way that no one should graduate from my school without having, at least a facility with the basics of biostatistics and epidemiology. Similarly, I would say no one should graduate from a school of public health without some facility with the basics of what communications and marketing looks like. Because you're right, that is the reality of the world, and it's probably always been true, but now it's much more individually driven than it used to be.
And very visible now. So Megan, I know we only have you for a few more minutes, and we've been talking a lot about communications, which obviously we love, but you've got other things going on. So it seems like, at least the impression I get from where I see you on the internet, is you are taking a personal interest and a personal stake in restoring trust in public health in America, whatever those holy institutions may be. It's kind of agnostic for you, it seems like. What else are you and your team doing to bring that forward?
Besides kind of like the larger team, what else are we doing?
Yeah.
So we're
okay. Yeah, what's going on?
Yeah. So, oh gosh, there's a whole bunch of things. We've got a big data project that's going to launch in a few weeks. That's being led by Ann Zink and Dan Weinberger, where we're braiding together different data sources to try to present to the American public, to the media, an approximation of the truth about emerging diseases in the United States. Right? When you look at one source of data versus another, they give you slightly different numbers and slightly different trend lines. So what is the reality behind kind of trends in respiratory illnesses or obesity? And how do we present it visually in a way that regular Americans can understand it, but also policymakers and healthcare providers and the media can get a better, more accurate sense of where numbers are. So that's one thing that we're working on to try to improve trust and allow people to think very locally about patterns of injury and disease. There's other projects around trying to teach our faculty, students, and staff communications. We're going to be launching a new comms course next spring, have some exciting new partnerships in the works there. And then some really interesting work around bioethics and nuance and kind of dissecting the COVID experience and the places where all of us made mistakes. Like every single one of us made mistakes. And I think there is a lot to learn, not in a was it a lab leak or was it not a lab leak debate, but rather at what point did we over-index on when was the tipping point where we should have stopped indexing on stopping infection or stopping transmission as the goal, and instead thought more globally about health? I don't think it was as early as the Great Barrington Declaration thought it was, but we probably could have moved a little faster towards thinking about kind of mental health and social well-being and obesity and opioid overdoses and all those other things in addition to infection. So I think there's some really interesting work for us to do in that space as well.
Well, and I just want to pull back to something you said before about, people, the disconnection and things like that, and people not having a personal relationship with the people who are providing them medical care, to say nothing of public health, right? That's like a global societal ill, and one that's very evident here in the US with like disconnection and friendship and community connection, those kind of things. But like, not to be too dramatic about it, but I really feel like I mean, the best thing that could happen out of this like current wave of technology innovation, AI or whatever else, is that we somehow make a dramatic change where we are highlighting and allowing, individuals, doctors, nurses, community providers to deliver care hands-on and have absolutely every possible administrative and technology thing fade into the background. Like that's still like obviously like blue sky, we hope, fingers crossed, but like that's the best outcome we could have here if we can actually do this. And it feels really critical and just like breaking point to me right now when I think about that.
I couldn't agree more, Lisa. And I say, as an emergency physician, one of the things about being an ER doctor is that we see all of the problems with society, but also with the healthcare system magnified. And right now, technology gets in the way and makes our life harder. And we're still picking up the pieces for the societal kind of breakdown. I love the vision that you articulate. I think it would be absolutely amazing. And we had the Yale Innovation Summit the past 2 days. And I will say that my plea, we're doing a lot of entrepreneurship and innovation work at our school as well. And my plea to entrepreneurs is to not think about your solution in this like really narrow little bubble as if it can exist in isolation. Like we need to be dreaming big about systems change. And, I am horrified by the disruptions and destruction that are occurring right now. At the same time, the system needed to change. And this does give us, if I kind of do the yin and the yang, maybe we can lean into an opportunity to create some really big, bold shifts to braid public health and healthcare together more closely and to make healthcare providers' lives easier and thereby help patients feel more cared for. I couldn't agree more with what you said. And I think tech has to be part of the answer, but it has to be done ethically and again, on a systems level, rather than a bunch of piecemeal solutions that nobody knows how to put together.
That's a beautiful wrap up. That's a bow.
Well, I know if we have 2 more minutes, I know the commander, I don't know if you guys know each other. He actually, look at him. Hey,
hello, Commander.
You're on camera.
Internet.
Commander.
I know you have a question for Megan about the Yale Innovation Summit, which she just brought up.
You are muted. There you go.
Oh, please
we still can't hear you, bud. You are talking and nothing is happening.
I see his mouth moving.
We can't hear you.
Well, it's good we're figuring this out now.
Select.
Well, we'll see if he starts talking. But Megan, tell us.
No, we cannot hear you now.
We
gotta try again.
But I want to talk to you, Commander Banyas.
Can you hear me now?
You gotta select. Yay! We got you.
Okay.
Wow, all three of us did the jazz hands. I just have to say,
Megan, this is an all new
we're jazz hands people.
So I'm from. My mom was a clinical nurse researcher at the School of Medicine and at the hospital. I grew up in the Yale ecosystem. So
this is an all New Haven show, and I was going to come up to the Yale Innovation Summit, but I just couldn't swing it. My question for you is, so I am currently the Small Business Innovation Research Program Manager at the National Institute of Minority Health and Health Disparities. So one of the things that I'm seeing, because we have a funding opportunity out right now that's due on June 11th, and it's going to be open again in December, and it focuses on health disparities populations. I am seeing so much like concepts, because I focus on health access for the most part. A lot of it's focused on weight management and using AI to help deliver public health. What do you see as like the three biggest like opportunities, particularly emerging public health into healthcare delivery? Because that's what I'm looking for. And like, I think the federally qualified health centers are a terrific opportunity. I used to oversee for HRSA, Fairhaven, and Cornell Scott. So I'm very familiar with the health centers there. And lastly, I'll just say this. I also oversee the loan repayment program for early stage investigators. So the first time I ever heard your name is in our L70, we have gun violence as one of our priority areas.
Thank you.
And that's where Jen Goldsack tried to connect us, because that's
I love this boy situation.
I wanted to know who was the who's who in doing gun violence safety and what programs to target. So that's how I came across your work initially, and then you came to Yale. So
that's well, you and I should definitely connect offline. And Lisa,
I come to New Haven all the time, so
yeah,
it's
perfect.
So,
Michael, she has to go.
I do have to go to something, but really quickly, I think that for kind of the big innovation ideas, I think you are 100% correct about thinking about there's a lot that can be done in FQHCs in terms of both clinical decision support, but also kind of the whole ideal behind digital health of reaching people outside of the clinic. The way that I got into digital health work was actually when I was working in East Africa. They were using text messaging to improve adherence to antiretrovirals for Kenyan villagers with HIV. At that point, there were no digital health interventions in the US, right? Each text messaging was still 15 cents a text here. And I was like, oh my God, this is the most brilliant thing. And yet we have not yet translated that effectively here on a systems level into the United States. So that is one. The second space around disparities is around rural health. I think we spend a lot of time thinking about urban populations, and we should, because most of us live in urban areas. But our rural healthcare systems are being absolutely decimated. Our rural suicide rates are out of control. Our rural violence rates are out of control, obesity, hopelessness. And I think there is some real incredible innovation that could be taken on kind of in that rural healthcare system. And then the third space actually is around environmental exposures and helping people to think about ways to quantify and then act on environmental exposures in a way that reduces disparities, whether those exposures are light pollution or noise pollution or chemicals in their environment. We have a researcher at our school who's doing really neat work with wearables to detect particulate matter. So for example, after a wildfire, not just smoke, but all of the other kind of things in the air, how do you know it and judge it? And I would be remiss to not talk about mental health, which talk about disparities, whether it's stigma or access. I think there's so much opportunity for innovation there. And I love the SBIR program. So really, I've been fortunate enough to have it.
I will. Jen has Jen sent me your email. I would love to connect on both the loan repayment program and
Commander, this is not your networking event. It's our networking event.
I'm sorry.
You can send her a love letter over the email.
I look forward to it. I do have to run. Lisa,
thank you so much.
Thanks for this dating opportunity. No, just kidding. I won't tell my husband. No, but seriously, Commander, it's really nice to meet you. Look forward to chatting.
Thank you, Dr. Ranney. I highly respect your work.
Thank you, Megan.
Thank you so much. All
I
right,
love that everyone's calling you the commander now.
This is working out for everybody.
Thank you, Megan.
Talk to you guys soon. Bye.
Oh my gosh!
Amazing.
All right, if it helps, while I was also multitasking and looking up hotel bars to meet Angus with, and you too.
Oh, okay. Well, Commander, I don't know if you know that 1 million Americans are currently watching the Health Tech Talk Show. What's going on?
1 million.
We're all going to go to the bar with you now. Don't tell them where you're going. What's going on? So we missed our special episode with you. So you've got this grant opportunity open. Tell the people.
So I know this is coming up quick, but I'm going to share my screen. But on June 11th, and this is going to be open again in December, we're going to have Innovations for Healthy Living, which is mostly a digital health and health disparities focused SBIR, which is Small Business Innovation Research. That's going to be due. And a number of NIH institutes are participating in it. I'm trying to get it up. So it's due June 10th, and it focuses on technology, services, and products dealing with clinical trials to disease self-management, technologies focusing on disease self-management, patient healthcare providers, system communication, monitoring, electronic health record APIs, because it's great if you develop, an app or a system that's dependent on data, like such as artificial intelligence, but it's really helpful if you can go into an institution's electronic health record and the API is built for, like, say, an Epic system. It has a focus on clinical trials and digital therapeutics using big data and other data scientist training, workforce training, social determinants of health, and National Institute of Diabetes, Kidney, and the other thing, so there's a number of NIH institutes that are signed on to it. The other thing I wanted to say is for the last year, I've been working on a women's health SBIR, focusing on gaps in women's health. And while that hasn't been released yet in the new administration, these are the gaps that we identified that are public for that SBIR that people are talking about, like at some of these big finance conferences, such as Teen Girls, Social Determinants of Health, autoimmune diseases. And this SBIR opportunity in June is a perfect vehicle to help fund women's health companies focusing on NIH-defined health disparities populations, such as minority health populations, people with disabilities, rural health, low socioeconomic status. And, women's health products are still startups are severely undercapitalized. So this is a great SBIR opportunity to also get people that have women's health focused products to apply for an SBIR and get funding.
Yeah, awesome. Well, and I know Lisa and I did a super special JPM show with some of your grantees. One of whom sounds like they have really crossed a milestone, Teal Health.
You want to know how I refer to it as a lightsaber?
Yes, I do.
Well, she, like, Kara, who is an awesome CEO. Yeah, so I watched that video a couple of times, and I love my face because that was the first time I had seen the product.
When she whipped it out,
she lives by Lucas. She actually lives by Lucasfilms in San Francisco. So I thought,
just to be clear, if you didn't watch it, Teal Health is a really innovative, really cool design self-collect pap smear device, and it's super unique, and the outcomes are really good, and it just made it, and it's they were an SBIR recipient. So
yes,
really cool.
National Cancer Institute, they got a phase 2, and
Yep.
they're going to be applying for additional phase 1s to go into different markets from us. But
and they just got device approval, which is the big deal is they got FDA approved. So.
Yeah, and that's something I think for a future show would be great for you to have her back on and just talk about the approval process and the new administration, because FDA has been severely impacted, just like the other agencies. It's just I think it's important for the private sector to know what they're getting into as they start to apply and get device and drug approvals.
Yeah. So, Commander, tell the people just a little bit more about why. So, sometimes in the great free private sector, we hear entrepreneurs saying, "Oh, SBIR grants are so hard to get and they take forever," right. And it's I'm just going to go after venture funding. But tell our loyal fans why these are great tools. I think obviously going to device.
I would. So small business innovation. So across NIH, there's $1.4 billion a year that goes out throughout all the institutes to early stage companies and entrepreneurs to help support the federal R&D mission. It's great for applying to SBIR program. The SBIR program is great for four reasons actually. One, you should always look at it like, I'm not going to get a check now. Maybe I'll get a check or funding in 9 to 12 months from now. So it forces you to have that business development conversation. What markets do we want to go into? How do we want to continue to innovate? What other functionalities do we want to add? And we might need to test for usability, say for phase one grants, which are $314,000 for a proof of concept. But it forces you to have that business conversation. Second, we kick the tires on these concepts through the science. So you go to a 3-person peer-reviewed panel that assesses the concept by your team, your significance, the problem, the innovation, the approach, the environment. So unlike maybe a venture firm where they're just looking at profitability in the short or the long term, we're just looking at the science. And there's a lot of times you'll get feedback from these 3 reviewers, and you might not realize that there's a hole in your science or there's a little bit of a weakness. So in that, score sheet, even if you get like a good score, you get reviewed, like that goes a long way, especially as you're looking for partnerships, but also helps with the business development conversation. The third advantage is that this is a grant. It isn't a loan. We do not take any equity. You keep all the intellectual property. We are funding you to contribute to the NIH mission and to work with the private sector in helping commercialize research and technology. And then the fourth reason is, it's prestigious to say you're an NIH funded company. It opens up a lot of doors.
Yeah.
So those are the 4 reasons, but business, it has that business development conversation, the prestige of the grant. It is a grant, and then also getting that scientific review, which is free. You're going to get comments back regardless if you get scored or not.
Yeah, I think a lot of people don't always realize that this is non-dilutive funding. It's kind of the U.S. government taking a bet on American businesses, right?
We're taking on the risk. We're taking on the risk to take something like a teal health product and help invest in it so that innovation can come to the market. The other thing I wanted to add was you do not need to be a PhD or a doctorate to apply, which is like how most NIH grants are. It's open to everyone. It's open to, you don't need a degree. It's open to college students. It's open to business students. It's open to public health students. Like it's open to everyone. So unlike most NIH grants where you need to be on that academic research track, this is open to just give me an idea and we're going to kick the tires on it.
Yeah. There's a lot of people we know in our network who would meet some of these criteria. And, we would encourage you. Commander's available to talk about it. And there's all the pathways that you see there, but it is due in like 10 days. So you gotta.
Yeah. So one thing I
gotta
want
get
to
on
add
it.
is, so that's a little short, I know, but there's going to be a general funding opportunity, which we call the omnibus, which is just the general SBIR funding opportunity. That's in September. And then Innovations for Healthy Living, this funding opportunity is going to be, it's going to be due, like the second round is going to be due in December as well. So you've got, within 6 months, couple months, you've got a bunch of opportunities to apply to a bunch of different NIH SBIR opportunities.
Yeah, and the commander will be, it sounds like, out and about at New York Tech Week next week. So you should hassle him for a meeting, probably.
That's right. That's right.
Yeah, fill up that.
If you're going to be there, talk to the commander.
Talk to the commander. He's around.
That's great.
Yeah. Well,
Are we gonna joke around, or is that it?
No, that's it. We just did your pitch for you. We just closed it. We just said
this is my third appearance.
That's right.
We've got 2 more minutes if you want to tell a joke. What do you want? What do you tossing?
It's a Friday. I'm gonna go take a nap after this. A long week.
Nice.
No, but thank you for talking about this. I really am pro SBIR grants.
Yeah. It's great.
All across, I mean, and they're all over the place, and not just for healthcare. I think it's awesome that they're here, especially given our kind of sometimes ridiculous healthcare system and some of the regulatory approvals that are required for certain technologies, but so important.
I think, one of the things is, Kat, you and I often talk about, markets. This is a great opportunity to use like a phase one to get into a different market, like a Latino market or a rural market. But, this is also an example of how the government, particularly at the NIH, works with the private sector to help invest in small businesses and companies to help grow the American economy. It's all about jobs.
I mean, yeah, like as I've said multiple times, that poor Lisa, I feel like Lisa's heard a lot of my propaganda speech on this call and earlier today. But yeah, this is a bet on American business, and America is the freaking best. So I love that we are funding American businesses to be the freaking best. So hopefully all these programs continue. I actually once we're done going through all these reorgs with the great federal government, I do hope they pour fuel on small businesses. And I think SBIR grants are a great opportunity to do that. So thanks, Commander. You're the best.
Thank you.
Thanks, America. Bye.
I guess we're done. See you, Lisa.